1, type 2, and we know type 2 is usually because the person is overweight, and we're seeing more and more type 2s, even in young kids, because they are chubby bubbies, like they're usually, you see a chubby bubby kid, usually you see the mother or father being chubby bubbies. Friends and family. And then type 1 is when the pancreas is really just not working. Okay, impaired fasting glucose and impaired glucose tolerance. Then you have another classification, and that's gestational diabetes, meaning when a woman is pregnant, she can develop diabetes. Classification during pregnancy is pre-gestational diabetes, meaning she had it before she got pregnant, and then gestational, when she develops it in the pregnancy. Okay. So a person who develops the gestational diabetes in the pregnancy, about 8% of all pregnancies result in this glucose intolerance, and it's from the hormones of pregnancy. And usually if you see it in one pregnancy, you see it in the next pregnancy, and there is a certain percentage of people who will go on later in life to become diabetic. This sort of risk factor. Okay. Preconceptual counseling for a person who has pre-existing diabetes. So what we want to do with a person who has diabetes before they get pregnant is get them into the preconceptual counseling. We want to make sure that their glucose levels are controlled. Usually postprandial, 2-hour postprandial, you don't want more than 140. Fasting can be 70 to 80. So you want to keep it in that like 70 to 80 to that 140 range, okay, prior to conceiving. Because if she has a high glucose level when she conceives, it can cause bone anomalies to the baby, cardiac anomalies. So she needs to control her blood sugar prior to getting pregnant and throughout the pregnancy. Okay. So tightly controlled. She needs to be taken off the oral hypoglycemic agent. Has a potential teratogenic effect. So she's taking something just orally. That's not glyburide. Then they would put her on either glyburide or they would give her insulin injections. Okay. So glyburide is one alternative to insulin that does not cross the placenta. They would also work with the woman with dietary management, maintain her insulin regimen, and there should be close maternal and fetal monitoring when she gets pregnant. Okay. Pregnancy of a woman with diabetes carries risk factors such as perinatal mortality and congenital anomalies. That's why tight control of glucose levels will reduce this risk. Yet many problems still remain for both the mother and the fetus. Okay. Hydramnios, which is also known as polyhydramnios, which is what? Too much amniotic fluid. Okay. So this is due to the diuresis. So the baby, amniotic fluid is mainly made up of urine from the baby. Okay. So the mother has this hydramniosis because the baby is urinating a lot because of the hyperglycemia. Okay. Preeclampsia, gestational hypertension can occur with people who are diabetic, gestational, or prior to getting pregnant. Hyperglycemia can lead to ketoacidosis, which can lead to a stillbirth. These people are also at risk for preterm labor. Okay. Premature rupture of the membranes, cord prolapse, urinary tract infections, and also yeast infections. Vaginal yeast infections are pretty high a lot of times with the diabetics. They can have a difficult labor, usually because the baby's big. A lot of times you'll see that people who have diabetes in pregnancy, the babies are large or large for gestational age. So they might have a difficult labor and a C-section possibly, and then possibly the post-partum hemorrhage again because the baby's large. You're just been stretched out further, just like the risk to the fetus, fetal death due to maternal ketoacidosis or poor placental perfusion, which can also lead to intrauterine growth restriction. Macrosomia, meaning macro meaning big and somia meaning body, so it's a large baby. Preterm delivery, respiratory distress syndrome, hyperbilirubinemia due to excessive red blood cell breakdown from hypoxia and an immature liver, neonatal hypoglycemia, okay, and then those pages again are from the old book, so take a look at your new book and just look up diabetes or gestational diabetes, and you'll see that. Okay. The hemoglobin A1C is a test that is performed on the patient usually right around the time she gets pregnant. They'll do it a couple of times, okay? And what this test will do is it will show the average glucose levels that are in the blood for the last 100 to 120 days. Okay, so it will show if her glucose levels have been too high, again, that puts her at risk of having abnormal, they being born with some abnormalities. A value of more than 8% indicates non-control of glucose levels. This level or higher at the time of conception puts the fetus at risk for congenital malformations or miscarriage of the pregnancy. The most common associated diabetic occurrences with the fetus is renal problems, cardiac problems, skeletal problems, and CNS disorders. So it really is important that she keeps her levels well controlled prior to pregnancy, okay, and during pregnancy, so these things don't occur. All right, so management is therapeutic management, pre-conception counseling, if she had it already before she was pregnant, tight control of her glucose levels, nutritional management, hypoglycemic agent, post-maternal and fetal surveillance, and managing during labor and delivery. Monitor glucose levels in the pregnant woman. Urine checks for protein and glucose. You can check for glucose also. If found, you need to be evaluated for gestational hypertension. Urine checks for leukocytes, which may indicate a urinary tract infection. Urine checks for ketone may need to evaluate the diet. They'll do kidney function tests each trimester in the pregnancy. Eye examination in the first trimester to evaluate the retina for vascular changes. And then the hemoglobin A1C every 4 to 6 weeks to monitor the trend of glucose. Okay. So what other tests would you do? Okay, so for testing for well-being, they'll do that quadruple screening test, the AFP test. We talked about that. They'll do the biophysical profile, fetal movement count, non-stress tests, echocardiogram, as usually done around 20 weeks gestation to rule out any cardiac anomalies that occur. Again, there might be an indication for cesarean section because the baby is large for gestational age or macrosomia. Or if the baby has non-reassuring fetal status, meaning the biophysical profile is not as high as it should be, the points, or that the non-stress test is non-reactive. Vascular changes also in pregnancy can cause different problems with the pregnancy itself. Okay, postpartum. Breastfeeding should be encouraged. This will lower the amount of insulin required, so they will really encourage that breastfeeding because of that, so she won't need as much insulin. Maternal control of glucose is essential. At the first pre-gestational diabetes, may require, after she delivers, if she had gestational diabetes, meaning she developed it in pregnancy, she no longer needs insulin after she delivers because the placental hormones are causing her to have the diabetes. Once the placenta's out, the glucose goes back to normal. We'll go check it the first couple of days just to make sure. Okay. The gestational diabetic have a 50% increased risk of developing type 2 diabetes in their lifetime, so that's quite high. Screening will be done at 6 weeks postpartum for follow-up appointment. Encourage a good diet, weight control, and exercise. They usually recommend a barrier method of contraception, meaning a diaphragm or condoms. Antihypertensive or antihyperglycemics are contraindicated during breastfeeding, so they'd rather them take insulin if they have to take anything. Insulin requirement in pregnancy, labor, delivery, and postpartum. Now, this again is you know, this is for like 95% of the people. You're always gonna hear one person come up with, well, I know somebody who, but this is how they actually, will say, typically for a pregnant woman who has diabetes already, okay? So how, the pregnancy alters the, need for insulin. First trimester, there's a decrease in need for insulin, and that's because the woman might be throwing up, okay? So if she has too much insulin, she's gonna be hypoglycemic. So what you have to do is monitor the woman, and you're gonna see that, you know, in the first trimester, usually there is a decrease in need, okay, for the insulin. Are you gonna quick change your page? Hurry. Hurry, act like you care.
I had my hand right here.
Okay, so we used to have a policy, we'd have to walk around, I don't know, it's still, they change policies every week, I think. If you find somebody not on what you're doing, then you throw the students out. That's one of the policies, might be still in place. You throw them out of the classroom. Watch yourself. Okay, you know. All right, so here we go. So you have to know this. First trimester, decreased need for insulin. Maybe because she's not keeping her food down, okay? Second trimester, there's an increased need for insulin. The glucose use is increased because it's now going into the fetus, okay? But what happens is this hormone, in the second and third trimester of pregnancy, you need to have more insulin because there's an additional increase of this hormone called HPL, human placental lactogen, are produced, okay? And this is a growth hormone also is produced. And what that does is that HPL and growth hormone acts as something disruptive to the insulin, like it's a barrier to the insulin from working, okay? So what happens is you need more insulin during that time because of these particular hormones, okay? So these hormones will act to make the body need more insulin because it does something to inhibit the amount. Labor, there is a decreased need for insulin because she's usually NPO, but they will be taking her blood sugars throughout labor. And then postpartum insulin needs will also decrease because if she's breastfeeding or because the hormones of that placenta are out from her. Okay. Now, prenatal screening. So this is what happens when a woman is pregnant, does not have diabetes to begin with. Okay. They will routinely screen all women between 24 to 28 weeks gestation. Why that time? Is because that's when the hormones come into play. Okay. So these two hormones, what will happen is, with these two hormones, it will cause the woman to have more glucose in her system. The insulin doesn't work as well. In a healthy woman, shouldn't be a problem, but a woman who has a tendency to go towards this gestational diabetes, these hormones start to increase and are, really at their peak around 24 to 28 weeks. So if risk factors exist, you would screen the person prior to 24 weeks if she is like overweight or had a large baby the last time, or she had diabetes in her last pregnancy. And the screening test they do is a 1-hour glucose tolerance test. They give you 50 grams of a sweet solution. You drink the solution, and then 1 hour later they will take your glucose levels. And if a level is above 140, it's considered abnormal. Okay, over 140, it's considered abnormal. Okay. If she comes back with a value of 142, it's abnormal. She'll have to go for a 3-hour glucose tolerance test. Okay. With the 3-hour one, they will do a fasting blood sugar on her first, give her 100 grams of this oral glucose solution, and then test her glucose level 1 hour later, 2 hours later, 3 hours later. So it's like, 3-hour glucose tolerance test. So, okay, so again, if she has 2 of the 4 values from from the 3-hour test, so she has a fasting blood sugar, gets the medicine or gets the glucose. It gets 1 hour after that, she gets tested, and 1 hour after that, tested, and 1 hour after that, tested. So there's 4 values they're looking at. If 2 of those values are elevated, she's considered gestational diabetic. Okay. So the goal is to minimize risk and complications. Gestational diabetes may be controlled by diet alone. So what they'll do is they will have the patient go to a dietitian, okay? And they will get on an ADA diet. And what will happen with that is they'll give her like a week or so to stay on the diet, encourage exercise, meaning, walking or swimming or something. And then they'll come back and they'll test her for a fasting blood sugar and a 2-hour postprandial test. And it should be that she, her fasting should be about 80 or less than 100. 2 hours should be less than 140. So if she stays like that, they'll keep her on the diet alone. If she doesn't stay like that, they're going to have to put her on insulin. Okay, so she needs to stay within normal range when she's on the diet. So they start with a diet, okay, and frequent prenatal visits, usually every 2 weeks up to 28 weeks, and then every week after that. You have to review the signs and symptoms of hypoglycemia and hyperglycemia with the patient. You want to monitor the glucose levels, her diet, her blood pressure, exercise. Glucose screening at least 4 times a day, okay? And that is a fasting blood sugar they'll do, 2 hours after breakfast, 2 hours after lunch, 2 hours after dinner. And sometimes they'll do it right before she goes to bed too, okay, just to see how it is. Okay. Review nursing care plan 20.1 and teaching guidelines for pregnant women 20.1. Okay, so the big thing is when I worked in this high-risk office, we would have our diabetic patients, gestational or pre-gestational diabetics, call in every single day at 4 o'clock. So we'd always say, 4 o'clock? You're diabetic. So yes, so they would call in at 4 o'clock and they will tell us all their glucose values for that 24-hour period. And if anything was up or off, we would change the dose of her insulin or maybe give her a regular insulin. So every single day it could be possible that we're changing her dosage, okay? Just to keep it so that it's really strictly within that normal range, okay? Okay, iron deficiency in pregnancy. Okay. This is very common in pregnancy. It's also common in women because of the fact they have menstrual periods. Okay, so iron deficiency anemia is one of the most common types of anemia. Usually due to inadequate dietary intake of iron. Okay. The therapeutic management eliminates symptoms, correct deficiency, and replenish iron. Okay, so some of the symptoms that you can see with a person who has iron deficiency is you can see the person being tired. Okay, but again, getting the pregnancy blood is also, so you have to do the blood test. Weakness, malaise, anorexia, more susceptible to infections. Okay, you get frequent colds. You have pale mucous membranes. You may get tachycardia and power when you're pale. Okay. Abnormal lab values, you're going to have a low hemoglobin, low hematocrit, low serum iron, microcytic and hypochromic, meaning small and not a lot of color in cells, and low serum ferritin. Okay, so those are, you come up with all these symptoms and then we'll do blood work. Again, that's pretty much the CDC, so the H and H is the CDC. Okay. Anemia risk. Anemia during pregnancy, early pregnancy can increase the chance of having preterm birth, a low birth weight baby. At term, anemia increases the risk of postpartum hemorrhage and infection for the woman. And also, if she does have anemia, it's causing less oxygen in the red blood cells. The baby's getting less of that oxygen that they need. So the baby could suffer from, having problems because of that. Hemoglobin level below 11 and hematocrit levels below 35, low iron less than 30, and then low ferritin less than 100. Management, compliance with drug therapy, prenatal vitamins with iron supplements of 30 milligrams each day. Best absorbed, take iron between meals, consume food high in vitamin C. Avoid taking it with coffee, tea, chocolate, and high fiber foods. Dietary instructions, counseling about increased your meat intake, green leafy vegetables, legumes, which are beans. Dried fruit and peanut butter also contain iron in it. So, okay, so this talks about the exam. Before, I just want to tell you one more thing about diabetes in pregnancy, which is important to know. If the mother is diabetic, okay, so you might want to write this down. If the mother's diabetic, and let's say, you know, she's producing a lot of sugar, right, and some of the sugar goes to the baby in the last trimester, so the baby uses the glucose for energy when it's first born, right? So it's stored in the liver for the baby at first. So when the mother delivers the baby, what happens is the baby is now always just connected to the mother. And if the mother has high glucose levels, the baby would increase its insulin from its own pancreas, okay, to combat the mother's high insulin, high glucose levels, okay. So the baby's used to regulating its own glucose levels in its body and tries to fight back what the mother keeps giving them. So their insulin levels keep working to make everything normal with the baby. When the baby comes out of the, they cut the cord and comes out, the baby is at risk for hypoglycemia. Why? Because it's still putting out a lot of insulin, thinking it's combating its mother's sugar. Okay, so it's used to doing that for the last few months, putting out too much, enough insulin to keep it normal. So now, when the baby comes out and it's not having the mother's insulin, I think more glucose in it from mom, the baby keeps putting out insulin, thinking it's combating. So the baby is at risk for hypoglycemia. Everybody get that? Okay. So a lot of times people are like, how can that be? But that's how it is. It spikes mother's high levels. Okay, so here we have, for the exam 3, okay, chapter 12. So in the old edition of the book, page 299 to 308. The new edition is 354 to 372. And also page, in the old edition, 258, here's a synopsis of all the different prenatal testing. It doesn't talk about non-stressors. It talks about amniocentesis and all that stuff. Page 305 in the new book. Okay. Chapter 19, including information about and all the medications in the chapter for preterm labor, hypertension, must know max sulfate signs of toxicity and side effects, an antidote. Also, go over all the information covered in the slides. Chapter 20 is diabetes and iron deficiency anemia. Okay, so that's for the exam next week. So, any questions about that?